Okay. Hello all, Mingalaba.
Mingalaba.
I'm just going to share my screen. Let's see if this works. Okay, here we go. Well, first and foremost, I'd like to thank the organizers for this talk and thank you for your time on a Sunday. So I've been tasked to talk about successful strategies to increase H.Pylori eradication. Now, this bacteria was discovered back in 1982 by Barry Marshall and Robin Warren. They actually won the Nobel Prize in Physiology or Medicine in 2005. This discovery of the bacteria has basically caused a paradigm shift. For years, we thought peptic ulceration was due to lifestyle factors and stress. But back in 1985, I suppose you can do it then, but can't now, that Barry Marshall actually proven himself not to be infected with Helicobacter, and then subsequently he took a dose of the H. pylori and basically demonstrated the causative effect of a H. pylori infection and acute gastritis. That's how the link was made. Now, since then, there has been almost 45,000 publications to date. And every year, there's more than 1,500 publications still ongoing on just the topic of Helicobacter. Now, the prevalence varies geographically. The main risk factors, it increases with age in levels of lower education and in developing countries. Now, why do we care? Well, since the discovery, we found that most peptic ulcerations are associated with Helicobacter. So 95% of patients with duodenal ulcers carry the bacteria, whilst 80% of gastric ulcers are infected with the H. pylori. The lifetime risk of peptic ulceration in patients with HP is about 3%. It causes chronic gastritis and is a known primary risk factor for gastric cancer. It is categorized as a group 1 carcinogen. The risk of gastric cancer increases with the duration of infection, particularly it's over 10 years. It also increases the risk of GI maltoma, or lymphoma. So under these circumstances, what are the indications to test for and when do we treat this H. pylori infection? Well, since all patients with positive tests of active infection should be offered treatment, the critical issue is which patient should we test for the infection rather than test everybody. Certainly, patients who have had active or past history of peptic ulceration should be tested. Patients with known gastric lymphomas or previous history of early gastric cancer. Any patients with dyspepsia, patients who are starting on long-term aspirin or non-steroidal, so that we can reduce the risk of GI bleed from ulceration. And in some patients with unexplained iron deficiency anemia or idiopathic thrombocytopenia. Now, I was working in the UK and this was a very popular method of treating H. pylori in patients who has dyspepsia and not to overload the services of the endoscopy center. So patients who are less than 60 years of age without any alarm features such as bleeding, anemia, unexplained weight loss, we would do a serology test, and if it's positive, we would then offer H. pylori treatment. Now, certainly that's not my practice. I'm a little bit more aggressive in the sense that I think the risk of gastric cancer in this part of the world is slightly different from the Western Hemisphere, in that our risks are generally a little bit higher, particularly in the Japanese, Korean, and Chinese population. So in my patient, anyone with above the age of 40 with persistent symptoms, I would certainly offer a scope as an endoscopic assessment. Now, as I alluded to, the prevalence of H. pylori in Asia varies. So in Singapore, it's about 31%. It goes as high as 92% in Bangladesh. In Myanmar, they did a literature search. It's about 48%. In places like Vietnam, it's up to 75%. Now, the main causes of eradication are non-compliance, followed by drug resistance, and perhaps a selection of PPI. I won't touch much about non-compliance, but suffice to say, on a 1 daily dose versus a BD dosing, for one single tablet, the compliance can drop by as much as 25%, and these are all published. Now, unfortunately, with the HP eradication regime, we started with dual therapy for 7 days, then 10 days, we then increased it to 14. Subsequently, we had triple therapy, and now we're on going to quadruple therapy. And all this is because of the drug resistance. Now again, the pattern of Helicobacter antibiotic resistance varies in ASEAN country. In Singapore, clarithromycin resistance is in the region of 17%, metronidazole is 48%. As you can see, some countries would have higher clarithromycin resistance, such as Vietnam, 30%, and metronidazole, 70%. Now, in particular, these two resistant profile impacts the cure rate. We see very little resistance across the board in amoxicillin and in tetracycline. Now, this is important, which I will show you later on. Now, this is just a graph depicting the trend in Singapore over 1 decade from the year 2000. In year 2000 to 2002, our metronidazole resistance was in the region of 25%, going up to almost 50% by the time it was 2012, a decade later. Equally, the clarithromycin increased from 7.9% to 17.1%. The significant resistance rate for clarithromycin is anything above 15%. Now, this is a publication on the Vietnam experience. It's a bit of a busy slide. I just want to highlight the fact that in the early 2000s, triple therapy achieved eradication rate of over 90%. But in the latter years, as you can see, similar triple therapy, similar duration, we are only achieving rates of 60 odd to 70, 80%. Now, this is purely based on the fact that there are increasing clarithromycin resistance in Vietnam, also metronidazole resistance. So in the management of H. pylori, the Maastricht-Florence consensus report, in areas where there's high clarithromycin resistance above 15%, certainly a bismuth quadruple or non-bismuth quadruple concomitant therapies are recommended. In places where there are high dual clarithromycin and metronidazole resistance, then bismuth quadruple therapy should be the first line. What about in Singapore? Well, in Singapore, there's a publication on some local experience in one of our general hospitals here. At least over the past 2 decades, despite the increasing rate of clarithromycin resistance, it seems that clarithromycin-based triple therapy continues to have success of eradication exceeding 90%. However, the duration of therapy has been lengthened from has been lengthened from 1 to 2 weeks to maintain efficacy. And the current used empiric second-line therapy in Singapore is either 2 weeks bismuth quadruple therapy or levofloxacin-based triple therapy comprising of PPI, levofloxacin, and amoxicillin. In my practice, however, I see quite a number of international. So what I have done is actually my standard HP eradication therapy is a non-bismuth-based quadruple therapy. And this followed by an ASEAN survey back in 2018 that in clarithromycin and metronidazole resistance remains a very major problem. Again, they stipulated that the prevalence of clarithromycin resistance above 15%, standard triple therapy could not be recommended as first line, and quadruple therapy might be a better choice. And as I alluded to and shown you the data, amoxicillin and tetracycline resistance have very low prevalence, and perhaps in this region we should consider using these 2 drugs in the first line therapy. They also recommended after the failure of second line, they should have culture insensitivity. And that's what I follow nowadays. And recently I had a patient that failed second line and she had to be rescoped for culture insensitivity. And the turnaround time is about 1 week. And similar, the Bangkok consensus report, again, more or less states the same. If the clarithromycin resistance less than 15%, standard triple therapy for 14 days might still be useful. Second line therapy we should use antibiotics not used previously, or with antibiotics with low resistance, such as amoxicillin or tetracycline. So what about proton pump inhibitors? I think the main role of PPI clearly in the H. pylori treatment is to elevate the gastric acid, leading to an increased population of dividing H. pylori, leading to the bacteria becoming more susceptible to antibiotics. By increasing the pH, it also reduces the degradation of antibiotics that are susceptible to a low pH environment. Hence, maintaining a gastric microenvironment of a pH above 6 is the key factor in the eradication of H. pylori. We know this because in early studies of standard triple therapy versus dual antibiotics without a PPI, the eradication rates were 68% higher in PPI-containing regime. Now, the effect of PPI on acid secretion is dose-dependent. The higher the dose, we may get a higher gastric pH, hence improve the cure rate. Certainly, the genetic polymorphism of CYP2C19 plays a role. This is implicated in the metabolism of PPI. I'll show you some data that it actually does impact in patients who are extensive metabolizers. So what are the influence of PPI on the minimal inhibitory concentration of antibiotics? As you can see, metronidazole and amoxicillin before PPI treatment is relatively high in terms of micrograms per mil, and then it varies between individual PPIs. As you can see, with pantoprazole is 1.4, and cefprozil is 2.38 microgram per mil, and rabeprazole 1.18, and so forth. And it tends to have more impact in antibiotics containing metronidazole or regime containing metronidazole and amoxicillin, and less so in clarithromycin. And again, not all PPI are built the same. This is a chart showing acid inhibition on the first day of dosing, comparing 4 different PPI. As you can see, there's the placebo, there's the omeprazole 20, that's pantoprazole, lansoprazole, and rabeprazole. This is the gastric pH over 24 hours. This is the daytime and the nighttime. There are also differences in terms of their bioavailability of day 1, and also in terms of their response over the different genotype of the CYP2C19. As you can see, full dose bioavailability is available for rabeprazole, lansoprazole, pantoprazole, and certainly there's consistent response across all phenotypes and genotypes of the CYP2C19. So the importance of this polymorphism is that it affects the bioavailability of PPI and that it metabolizes it. Hence, it can cause quite marked inter-individual variation in terms of the intra-gastric pH, control of gut symptoms, or healing of esophagitis, and in turn affect the HP eradication rate. And it's our very early studies back in the late 1990s on the use of omeprazole. These are the extensive metabolizers versus poor metabolizers. As you can see, the Helicobacter eradication rate is much lower in extensive metabolizers versus intermediate metabolizers versus poor metabolizers, which they can achieve higher PPI concentration. And this is a slide on the use of rabeprazole where there is no difference in comparison between extensive and poor metabolizers in terms of the HP eradication rate. Now, we also need to understand what's the makeup of our population. So in Chinese population, just slightly over a quarter are extensive metabolizers. And in Caucasians, almost 3/4 of patients are extensive metabolizers. So I think knowing the makeup of these patients, then you can choose the regime suited for your patients. So coming back to the management of H. pylori, the Maastricht-Florence consensus report, I more or less follow this regime. So in areas of high clarithromycin resistance, which I think Singapore is, because our data actually shows that it's 17%. Hence, my first line is actually a non-bismuth quadruple therapy, PPI, amoxicillin, clarithromycin, and metronidazole for 14 days. I will use bismuth not as a second line for some patients. Patients coming from China has very high clarithromycin and metronidazole resistance. Similar to the Vietnamese patient, this would be my first line treatment regimen. What about alternative regimes? If bismuth is not available, levofloxacin can be used, rifabutin, and high-dose dual therapy, PPI plus amoxicillin. I'll show you some data later on. If tetracycline is not available, in high dual resistant areas, bismuth-containing quadruple therapy combining furazolidone plus metronidazole or amoxicillin plus metronidazole can be considered. Newer agents such as vonoprazan, which is a potassium competitor inhibitor, have shown, at least in Japan, that even with dual therapy versus a vonoprazan triple therapy, there are no difference in terms of eradication rate. However, this eradication rate in this day and age is probably not acceptable, as we should be aiming for a cure rate of over 90%. But at least it's a new agent that we may consider for patients who have failed multiple different regimes. So this is a slide on high-dose dual therapy in first-line treatment compared to patients having standard triple therapy versus sequential therapy. And you can see the cure rate is as high as 95.3% compared to the two different regimens. In patients with second line, you're still achieving almost 90% versus a 50 to 78% eradication rate. So in summary, I think the preferred first-line regimen should be dependent on local antibiotic resistance rather than any single recommendation. So you need to know what your resistance rate are to the two most important antibiotics, which is clarithromycin and metronidazole. And H.Pylori regimen should have a cure rate of at least 90%. In places where clarithromycin resistance is less than 15%, then clarithromycin triple therapy for 14 days can still be recommended. All treatments are for 14 days in areas where clarithromycin resistance is more than 15%. First line would be concomitant PPI, amoxicillin, clarithromycin, and nitroimidazole, or bismuth-based quadruple therapy. If bismuth is not available, then levofloxacin, rifabutin, and high-dose dual PPI and amoxicillin may be used. Thank you very much.